Well, good afternoon, everyone. It's a pleasure to be with you, and thank you for coming on Thanksgiving week, which is a short week for all of us. But as you know, this is our MCPAP Clinical Conversations session, which take place on the fourth Tuesday of every month. I'm Barry Servette. I'm the medical director for MCPAP, and I'm going to go over a few housekeeping issues, and then we'll get right into it. First of all, the topic for today is fighting stigma associated with children's behavioral health, primary care strategies. So as always, the session will be recorded and available on the MCPAP website at www.mcpap.com. A copy of the slides will be available on the site as well. And we will be happy to entertain questions throughout the presentation. Our program director, Beth McGinn, will be monitoring the questions in the chat, and we'll be glad to unmute you if you would like to ask it verbally, or you can just type your question into the system and we'll read it for you. At the very end, you'll receive a brief survey, and we really appreciate your feedback because we are continually trying to improve our program, and we want to meet your needs and make sure that our content is of interest to you guys. We have two presenters today. It's Dr. Marion Earls and myself. So we're going to be co-presenting, and we're going to introduce each other, and then we'll go ahead and get started. So I'm going to start with introducing my friend and colleague, Dr. Marion Earls, who is a developmental and behavioral pediatrician. I've been lucky enough to have been working with her on many projects over the years. And so she's definitely an old friend of mine. She is originally from Massachusetts. Actually, she's in North Carolina and has had the bulk of her career in North Carolina, but she is one of us from Massachusetts, and she graduated from the University of Massachusetts Medical School. One thing I did not know about her, actually, until reading her bio, is that she has a master's in theological studies from Harvard Divinity School, which she did before she changed gears to get her medical education. Perhaps that earlier interest explains or influenced her career long interest in mental health in aspects of the mind, which is a close cousin to spirituality. But in any case, we can let her be the judge of that. I do want to say that her bio is, when we read it and looked at all of her accomplishments, I was overwhelmed because I realized that it would take probably the whole hour to fully really capture all of her accomplishments and leadership contributions. So I'm just going to go over some highlights. Marion's been a major force in the National Academy, the American Academy of Pediatrics, and a frequent collaborator with ACAP, the American Academy of Child Mental and Psychiatry, over many years. And she's participated and led numerous projects related to quality improvement, prevention, particularly mental health prevention, early childhood mental health, postpartum depression, screening and primary care, mental health competencies in pediatric primary care. It's really quite an amazing sort of collection of projects and interests, which really all kind of very much center around trying to improve the lives of children. I'm sure that she's really directly influenced the lives of so many kids, because in addition to all of her national work, she's maintained an active practice in developmental behavioral pediatrics, and she served as medical director for many years of a large nonprofit pediatric practice serving low-income families in Greensboro, North Carolina. She actually is the chair of the Mental Health Leadership Work Group of the American Academy of Pediatrics that promotes national dissemination of mental health integration in primary care pediatrics, and she's also a clinical professor of pediatrics at the University of North Carolina Medical School. everywhere I turn, I cross paths with Marion. I don't know how she manages to do everything that she does. She seems to have a reflexive tendency to say yes whenever she's called upon to serve a role related to helping children with mental health issues. And I'm a little bit embarrassed, but not at all regretful that I took advantage of that in asking her to join me in this session. So thank you, Marion.
Thank you, Barry. That was very, very flowery and wonderful. And it's interesting to be introducing each other because, again, I don't quite remember, Barry, when we first met. Maybe it was the ACAP committee work that I've been so fortunate to be part of with all my friends as child psychiatrists. And so, you know, you folks, Barry just introduced himself. He's been the medical director of MCPAT since 2004. You must have started when you were 3 or 4, Barry. You're so young. But he's been very interested in integrated care, which is something that I've had an interest in as well. And he has won awards from ACAP, the Simon Weil Award for Consultation Psychiatry. It's really a wonderful award to be winning from ACAP because it really reflects psychiatrists who are very interested in collaboration with pediatric primary care. He's gotten the Outstanding Psychiatrist Award for the Public Sector Psychiatry by the Massachusetts Psychiatric Society. He has been a founding board member of the National Network of Child Psychiatry Access Programs. You know, the wonderful program that he has been the director of, and then the many CPAP programs now that are growing around the country, which is really exciting. And he's someone who's always worked with primary care to help primary care do a better job with mental health competencies in the kids that we see. So Barry and I worked together on a quality improvement project for many years with Johns Hopkins, helping practices implement trauma and resilience informed care and really understand how you have those collaborative relationships with mental health professionals and primary care. So really excellent work, excellent outreach to primary care and understanding of how important it is to do that integrated work. So that's something that we definitely have a passion for, you know, in common. Now, the other thing about Barry Sarvet that's not in his bio is that he's a musician. And I've been really impressed with the times that we've been together to hear him play the fiddle. So maybe there won't be time today to do that on this talk, but a real Renaissance man and a delightful friend. So shall we get started, Barry?
Yes, thank you very much, Marion. So we both have our secrets, you know, yours with the divinity school background and my fiddle playing, which many people don't know about. In any case, we're going to go right ahead. This particular session is going to be a little bit different in that we are not going to be sort of going through a lot of, you know, sort of slides, but I wanted to start with a few slides and really move from that into a conversation. So Marion and I, when we were talking about doing this together, we ended up having what I thought to be just a really interesting conversation about stigma and how primary care practice, particularly in pediatric primary care, can really help to fight the stigma of mental health conditions in kids. And so we wanted to try to replicate that conversation in front of you guys. And also bring you into the conversation and hear from you. So we want this particular session to be in the spirit of the title of the program, really a clinical conversation, as opposed to just us telling you things and giving you lots of information and things like that. But just to kind of set the stage and to sort of provide a little bit of a framework for the conversation, I wanted to go through a little bit of material in slide form on this, and then Marion and I will start talking to each other, you know, to kick things off. So just to start out, just as kind of like a framework, you know, this whole issue of stigma in pediatric mental health and mental health in general is really a field that has not been studied very well by psychiatry and by the medical sort of profession, but it's been more kind of living in the field of sociology. And so some of the definitions here come from the sociology field. And so there's a distinction between what is called public stigma and self-stigma. And another term that might be used to describe self-stigma is the internalized stigma. So there's stigma in terms of other people sort of having negative beliefs about people with a certain condition or members of a certain group. And that kind of relates to all kinds of beliefs about this group that are exchanged and disseminated in society. And it involves prejudices about, it's all similar to belief, but stereotypes and prejudice. And then it also involves actual behavior. So people do behave differently towards stigmatized groups of people, oftentimes in terms of avoidance, but also sometimes discrimination is more active. And in child behavioral health, that's where we get into bullying. So kids with mental health conditions in schools can be bullied by their peers, obviously, and also can be harmed, by the way that they're treated in disciplinary sort of situations. The other side of stigma is really the internalized or self-stigma. And that's kind of where people who are members of the stigmatized groups, they harbor internal beliefs about themselves that are based on sort of the experience of stigma in the society around them. And they often have behavioral responses to that internalized stigma, in the sense that they, might sort of avoid certain situations. They might behave differently with other people because of this internalized self-esteem issue, really, which is related to stigma. So I just want to discriminate between those two, or really differentiate between those two particular aspects of stigma. So in terms of mental illness, there's a term that's referred to as the double jeopardy of mental illness, and that really corresponds to the fact that people suffering from mental illness are not only experiencing pain and sort of symptoms that contribute to suffering from the mental illness itself, but the double jeopardy is the shame associated with the stigma, which is externally imposed upon them as members of this stigmatized group, as well as internalized. And so that's the term double jeopardy. As we know, kids don't have access to care, and we often talk about the systemic issues in terms of access barriers. But what's not talked about as much is the fact that many people don't access mental health services because they are ashamed of admitting that they have a mental health problem and acknowledging that. And that's related to stigma. So it's not only an externality in terms of wanting to make it easier for people to get services and workforce shortages. It's also a fact that people don't seek out the help because they are feeling ashamed, or because they're afraid of being blamed and stigmatized for identifying a mental health problem in themselves. Now, of course, because this is really focused on pediatrics, we want to talk about aspects of this that have to do with children's mental health, particularly the impact of stigma on identity development, on self-esteem, and also talk about the trauma that's associated with bullying. But I also feel like mental health for kids, is as much about parents as it is about the children. And so there's a major parental dimension of stigma that has to do with parents being stigmatized because they are blamed for the mental health problems of their children. And that's kind of something that we don't talk about that much, but it's a legacy of the field of psychiatry in particular. But it's not limited to psychiatry, that many people in society make the assumption if a kid, kids are supposed to be healthy, this notion, that kids are born perfect and that they somehow only have problems because of things that people do to them and things like that. That's a prevalent belief, and it leads people to assume that most kids with mental health problems are really sort of have mental health problems because they have not been raised sort of correctly, and that leads to lots of negative interactions, and then there's also internalized stigma that parents experience that impact their ability to access services and their ability to really engage with treatment. So the other aspects of stigma for kids has to do with fears of violence. And so the media has really kind of played into this, but there's this notion that various times when there are events in society that are extremely disturbing, events of terrorism or mass shootings, there's this sort of pivot to, our kids are not well, and it's not the guns, but it's the crazy kids, that are responsible for this, and certainly, there's this kind of exaggerated belief that that mental illness is associated with violence, when the fact is that the vast majority of children and adolescents with mental illness are simply not a danger, but there's kind of a media narrative that sort of leads people to think that that their kids with mental illness are ticking time bombs, and it results in pretty dramatic sort of processes in school settings as well. And so this is just another cover from the New York Times magazine section, sort of trying to contributing to a narrative about kids with problems, being potentially dangerous. So these are just some of the beliefs, that are gathered together. This notion that children with mental health problems are dangerous, or that they're immature, they're irresponsible, that individuals with sort of underachievement, are sort of is because they have mental health issues, and vice versa, that the mental health issues cause people to underachieve, that the notion that they're weak, incompetent. There's a fear of infection, the sense that people don't want sometimes their kids to be associated with other children with mental health problems because that they might sort of, have a contagion effect. And then there's also a notion that people who have mental illness, this is especially true for adults, and beliefs about adults with depression, for example, not, simply just not being strong enough and not having enough responsibility to pull themselves up by their own bootstraps in some ways. We talked about the parent blaming. There is a notion, an aspect of stigma that leads people to think that that mental illness is intractable, that people can't really respond to treatment if they're mentally ill. And also this notion, this is something that we experience in the insurance industry, actually, this notion that mental health services have to be managed intensively because if they're not, they're just going to be used in unlimited ways. And the notion that if you pay for mental health services, it will be a bottomless pit, and there's no end to the spending that would be associated with them. There also is stigma against mental health professionals, which I actually have experienced myself, with assumptions that mental health providers would be foolish and incompetent, that they're not real doctors, psychiatrists not being real doctors, and also notion that mental health services are a waste of money. So stigma is measured. This is an old study, but it's actually been replicated and has not changed. There is a notion that stigma has sort of gotten better. And there's not much data to show that it really has, which, so there's kind of a belief that we've made a lot of progress, but I'm not sure that we have. For adults, it's measured by asking people, would you be happy to move next door to someone with different kinds of problems? Would you be happy to make friends with someone with different kinds of problems? Would you be willing to socialize Would you be willing to work closely with someone? Would you be willing to have this person be a member of your family, marrying into? And as you can see, that there is quite a bit of stigma against people, adults with depression, schizophrenia, and it's reflected in the majority of people not, wanting people in these categories to be members of their family or to work closely with them. In the pediatric space, the daily troubles kind of category is kids with behavioral problems, and so there's stigma against kids with behavioral problems, but kids with ADHD, that's, kids with ADHD are significantly stigmatized, as well as kids with depression. And so this is something that has been measured, and it's not really getting better, unfortunately. The notion of a medical model is an interesting topic, because one of the things that we've talked a lot about over the years, and the National Alliance for the Mentally Ill has really promoted this as an anti-stigma strategy, is really sort of making the point and constantly reminding people that psychiatric illnesses are medical illnesses, and that they have brain dysfunction, and there's kind of a chemical imbalance, for people with mental illness. And so it was actually studied, and it was found in studies that this notion of brain disease or chemical imbalance or genetic or biological causation of mental illness actually causes more stigma, which is paradoxical, at least, to people in NAMI. I think they're surprised to see this, because they've used this as a strategy for so many years to kind of try to disseminate this idea. But it doesn't help that much, and actually can make it worse, to say that people with mental illness have a chemical imbalance, because that sort of promotes this narrative of a defectiveness in people with mental illness. And it also makes it seem as if it's permanent, in the sense that you have this permanent damage. So lastly, I just want to point out, and the background of this talk is that, this is part of MCPAP, Clinical Conversations. And for many years, Marion and I both worked on integrating mental health into primary care. And we believe that in and of itself, that mental health integration actually has a function. And part of the purpose of mental health integration, in addition to improving access to care, is to fight stigma, by saying, look, it belongs in primary care because it's just a health issue like everything else. And it sort of normalizes the idea of mental illness as something that people struggle with, and similar to any kinds of problems that a pediatrician would handle. And it's placed in a wellness context, and PCPs obviously are in a wonderful position to educate people about different kinds of health issues and risks, and problems that can be addressed early. And so we feel like just by being here, just by being involved in mental health integration, you're already fighting stigma, to a great extent. And then the engagement methodology that can happen when you're doing warm handoffs and trying to promote coordination of care between mental health providers and primary care, it all helps with stigma. I guess the bad news is that it doesn't go all the way. That integrating behavioral health in pediatrics certainly helps, but it doesn't always help, and there are ways in which we can sort of have even a negative influence, even when we're integrating mental health. And so that's why we wanted to talk about this, to talk about how we can really be mindful of how to leverage the practice of mental health in primary care as a strategy for addressing and improving stigma. And so with that, I'm going to stop sharing my screen, and Marion and I are going to have a conversation. I think I'm going to open it up with Marion. And Marion, I'm going to ask you to sort of talk about the role of the PCP, or the pediatric primary care provider, as an educator, and what are your thoughts about how we leverage that role to address stigma? And we can kind of go back and forth on this.
Sure. Sure, that was great. It was a great summary of all of those considerations. There's two couple of things, right? So in my practice, I've, I've said before, I felt like I saw all the kids with ADHD in my county and everybody who somebody thought had ADHD. And it was interesting to me to see how hard it was to implement an intervention plan because of the stigma that was attached. For the kid who, by the time they were seeing me, had been completely vilified and was this terrible kid. The parents who were embarrassed because the teacher said things to them about their kid. And a big part of my role in seeing those kids was to demystify what was going on, and spend a lot of time trying to engage the family around the good things in their kid and the fact that this is a common difference and so on. And so there's that. And then there's the thought I had with some of the things you were talking about in primary care. In primary care, we have this advantage that we can have a longitudinal relationship with a kid and a family. So if we can start early talking about social emotional health as a part of health, that's that educator role, but it's also, conditioning people for every time you come to see me, we're talking about your child's social emotional health, not about problems, not necessarily a deficit model, but how's your child's social emotional health? That's the thing that strikes me. If we were doing that better, we would be having less issues around stigma when something is identified where a kid needs some support. That's, not a perfect solution, but it strikes me as so much of our role to talk about that as part of health. When I was leading the grant in North Carolina for the CHIPRA grant, we did a lot of work around mental health integration and that sort of thing. And it struck me that in health, in pediatrics in particular, we've separated the head from the body and the mouth from the head. So mental and dental were things that we didn't do. And I think what we understand now is we're seeing the whole child. So we have to understand that as part of health. Anyways, that's a place to start.
Yeah. No, actually, one of the things when we were talking before is that I thought was really interesting is about ACEs. That we've really spent a lot of time, I think, over the last 10 years and more, a couple of decades, really, talking about ACEs, as a major narrative that sort of explains to people why it's important to address early childhood experience and mental health. And that's led people to do ACEs screenings. But, at the same time, sort of on the point about how we can sort of unwittingly kind of reinforce stigma, there are ways that ACEs, talking about ACEs can lead people to really think of kids who have experienced early life trauma and adverse childhood experiences as being damaged goods, that sort of narrative of mental health issues being sort of damaged goods in a way. I worry sometimes that some of our educational approaches to ACEs can sort of lead to that inference, unless we kind of make a really good point or really emphasize the point that ACEs, is not going to be sort of a sort of a card, that's kind of indelible. This notion, because you look at those long-term outcomes, later in life, and it seems so depressing, but the work that's being done in ACEs is so hopeful, so what are your thoughts about education about ACEs and how that, can sort of be sort of leveraged in a way that actually reduces stigma and doesn't kind of contribute to it?
Yeah. Well, I'll say one thing, that I think that the recent statement that came out from the AAP, that Andy Garner, originally Jack Shonkoff was part of that initial thing about toxic stress, right? So kids who experience adversity, particularly if they don't have a buffering adult, then they have these kinds of outcomes, right? And I think what's fascinating is the more recent work around positive childhood experiences and the long-term impact of those. And paying attention to what's positive that's going on makes so much sense. You know, we worked together on that project where lots of people were all turned on about screening for ACEs. But the truth is, and once you started asking families about these things, you realize, hey, this family seems to have had some of the same experience as this family, but this family is coping with that really well. So what is the other thing that's going on? What are the positive things? How do you help people by pointing out to them what areas of strength and positive, you know, encourage those positive childhood experiences? That's not to pretend the ACEs don't exist, but it's to understand that a deficit model gets us in trouble all the time because we're not recognizing that other piece. The other thing is you have more credibility with the family. If you're able to talk, you know, really help them see, you know, the things that are good and the things that are really, really hard. But I think that if you do this and you really get engaged in asking those questions, you suddenly discover that there are these other things that are going on, and how is it that we do that promotion? So I'd encourage people to look at that new statement on toxic stress and early relational health, because it really talks about the evidence around things that we can do at the level of promotion and prevention, as well as intervention, that are looking at those positive things that are going on with families. We've been working on a project with the AAP with 7 states on opening visits by also not only asking about risk, but asking about family strengths. And people looked at us quizzically and said, how do I ask about strengths? And people spent like a year figuring out that, like, how do we ask about this? And then people saying it was so transformative to practice to have those really substantive conversations with families. So,
Yeah.
you know,
Absolutely.
I think that that's a real strong set of evidence that we should be thinking about.
Yeah. So let's pivot into talking about screening, you know, and assessment. And I think the point that you're making about sort of assessing strengths is something that is so vital. But as far as ACEs are concerned, you know, I do think that that we need to include sort of this discussion about resilience as a buffering sort of factor that really can sort of counteract, you know, the impact of ACEs into our education about ACEs. You know, because I think when we talk about ACEs, you know, we're sort of you know, reinforcing this kind of point that look, you know, mental health and early childhood experience is really important. You know, and so it's so important that we see its impact, you know, sort of 30 and 40 and 50 years later down the line, and it causes people to die and causes people to get all kinds of terrible illnesses, and it's a narrative that's very disturbing, and it has its purpose, but in the clinical setting, that narrative can be interpreted to be a narrative of toxicity. You know, so even the word toxic stress, you know, sort of reinforces this notion that someone's been poisoned, and so I think we need to kind of incorporate, you know, this idea of buffering and resiliency into our educational materials about ACEs, and I just don't feel like it gets there enough.
I agree.
Let's talk about sort of a little bit more about assessing strengths, because you know, pediatricians and psychiatrists and doctors of all kinds, you know, that we're taught, you know, to take an inventory of symptoms, you know, and an inventory of you know, all kinds of, we're looking for defects, you know, we're looking for bad things, we're looking for diseases and infections and, you know, things that are really focused on sickness, you know, and primary care does not have that exclusive focus. Primary care, and that's one of the nice things about incorporating mental health into primary care, because primary care is so much about wellness and prevention, but how do we assess strengths? You know, we often encourage people to fill out PHQ-9s and pediatric symptom checklists, and I'm just not sure we're being rigorous enough in terms of assessing strengths, you know, in primary care practice.
No, I agree. And most of the tools that people are using, I mean, our tools are for a deficit model, right? There are some tools that ask about strengths Like there's the strengths and difficulties questionnaire. I know a lot of my colleagues really like that for school age and adolescent kids to really get a sense of some of the strengths and so on. But I think being intentional about it, maybe it's not a screening tool, maybe it's part of the conversation you have about the screening tools that you use. So in my old practice, we routinely used developmental screening for 0 to 5, and then for school age kids, we used the pediatric symptom checklist. But it was always, you don't do a screen, and because it looks okay, you say, oh, good, I don't have to talk about that. It was always about, you have to have a conversation, respect the fact that people have completed a questionnaire and have a conversation about it. And so if everything looks great, you can comment on how everything looks great. And have you had any other concerns, or are there any other things that are going really well for your child that we should be talking about and knowing about? I think for adolescents, there are questionnaires that ask about good stuff. We did a survey during my time as director of pediatric programs with Community Care of North Carolina for Medicaid. We did a survey of adolescents asking them about things that they would like to have happen with their primary care visit, and overwhelmingly got responses that they would like to be asked about something besides sex, drugs, rock and roll. They'd like to be asked about what are the good things for them, what are their goals, what would they like to, what are they aspiring to, as well. So moving out of that deficit model makes such a big difference. I think being able to ask families about what's going well, what's the best thing about being Johnny's parent, what are the things, tell us about your family. What are the things about your family that are really great? I mean, there are ways to ask about this as part of the conversation. And I think that it's just something that people need to incorporate. It's not hard to do. It's sort of communication 101, because people really like it when you ask them about those things. And it is an opportunity to really understand how does this family, what are the things that they dip into to cope with these hard things that are happening? I think it's a really important piece of what we do. And if we do it all the time, then when the visit is about a kid who is having some behavioral problems or mental health issues, then you've established that that's the kind of conversations you've always had. That's what it seems to me. And in primary care, you have that option because you're seeing kids over time. It's harder as the specialist who has somebody referred to you because there's an issue. And it may not, you don't have the luxury of that previous relationship. But I think that's a real big piece of what we can offer to this.
Yeah, I agree, Marion. I think, as physicians, that when we're trying to figure out what's going on, we're sort of, have a tendency to be like pathologists, in a way, so that we're really, I guess the point is that patients, they can tell, what we're most interested in, and if all of our questions are about problems, then it sort of conveys a message that we see them as primarily a collection of problems and that we don't necessarily care, about their strengths. And I think that you're right, that we're not going to have screening tools, that are going to be, screening for strengths in the same way, because the whole point of screening is to try to identify, sort of diseases that we don't want to miss, and so, but I guess the point that you made is that a lot of times people, they hand out screening tools and they sort of skip the step of the conversation, about the responses to the questions on the screening tool, that it's really a two-step process. And in that second step, it's so important for us to know, what are the strengths, because it tells us about prognosis. It tells us about the significance, and the seriousness of the positive answers. It sort of helps us to understand the balance, of sort of the negative symptoms and the positive sort of qualities that can sort of help us to understand how much in trouble is this person, and how much should we be concerned about this person. And then, from a treatment standpoint, that most people, and this relates to stigma, but most people, if they're feeling ashamed of themselves, they're not going to be motivated, to engage in treatment. They're going to feel hopeless. and they're going to feel badly about themselves. But if we really show an interest in the strengths, and we really convey an understanding about how the strengths can be leveraged and need to be leveraged to address the problems, then that can sort of send a very strong message to families. So I like to think about the implicit messages that families receive based on the questions that we ask them. If we're asking them only about symptoms, then they're going to get the message that that's really what we see and what we care about. And if we ask them about strengths also, then they're going to know that we see that and that we care about it, and that's going to help them to feel more engaged, and more motivated to sort of follow through, with treatment.
And I also think if you have that trusting relationship, when you are the person that says it would be good to engage in this treatment, you're a more trusted person. And if you can make that as a warm handoff, it's even better. If it's, my friend Barry talks to people about this all the time. I'd like you to see Barry. I mean, that's one of the advantages of having the integrated mental health professionals. In my practice, we had 7 LCSWs, and we could have used more because they were part of the team. They were in the morning huddle. They saw families. They would indicate to the provider if to the physician or the nurse practitioner, I think I may want to talk to this family based on their history, that kind of thing. So it was a really wonderful kind of relationship. Or if I went into a room and the Edinburgh, the perinatal depression screen is positive, then I can say, Karen's part of my team. We work together. I'd like you to talk to Karen. And Karen develops a relationship and then helps with a connection in the community. If that mom needs therapy, that sort of thing. That to me is the advantage of the fact that you did all this promotion and prevention, and when the time comes, you have this connection, and hopefully you have a really good connection to your mental health colleagues, so that you co-manage well. But I do think that really reduces the stigma for folks when someone who's trusted is able to say that this is a good thing to do. Not in my experience, families don't really do well when you give them a 1-800 number, and they have to call and tell somebody all over again what the issues are, who they don't see, who in a place where the stigma is really significant, right? Because I'm having to do this, and what does that mean about me or my kid? So
yeah, I love the point. Oh, sorry.
Go ahead.
Oh, yeah, I was just going to say, I wanted to underline or just reinforce and agree vehemently with the point about that you make, which it's not just sort of having a resource available, to kind of hand off to, but it also has to do with your relationship with that resource. Because I've seen some implementations of so-called, integrated care, where the mental health clinicians who are in the practice aren't really part of the team. They're sort of available, but they're kind of really thought of as being external, people to the team. And so when an issue comes up, there's this quick sort of handoff saying, oh, well, I don't have time to deal with this myself. Or I really don't know anything about this, kind of issue. So I'm going to sort of have you talk to this other person, who can really, sort of deal with this, and there's sometimes an implicit message that I'm not really interested in this, this is not, part of pediatrics. This is something that's a nuisance, and so, but if that integrated behavioral health provider is really a member of your team and is your colleague, and is part of your practice and really part of the service, then you can say that, and that sort of makes a difference. I think that you're saying, look, we care about mental illness and mental health, in our practice. And we have a person as part of our team, who can help us, help me, as your doctor, to navigate this with you and to try to help. And so there's different ways of doing the handoff, I think, that can either reinforce, and I think most pediatricians, really want to, sort of, be supportive in this way. But when we get really busy, I think it's, there are times when those messages are conveyed like, I'm too busy to deal with this, so I'm going to ask you to see this other person, or I haven't really kind of been interested enough to learn about this, and I don't know anything about it, because I'm not a mental health person, so I'm going to have to send you to this other person who really knows this stuff, and that may be true, but I think we have to be careful about sort of how we articulate that. And I think it all comes down to, what is the relationship, between your integrated behavioral health provider and the rest of your team? And is this person really an integral part of the team? And if not, your friend, saying, my friend so-and-so who I work with and is working with us together, is going to be helping, and we're going to be here for you as a team. Yeah. So what are your thoughts about that?
Yeah, I definitely think that's the case. And what happened for us, fortunately, was that families often had met that person at other times as part of, we work together. We might even introduce ourselves to a new family. Like, we work together. You may see both of us. If you have any concerns like of this type, Karen's my partner to do that. That kind of thing it doesn't take longer to do that. And it really does make I think it's exactly the way you want to do it. Now, you know what? Sometimes you don't have the luxury of that, right? There's not like volumes of people to come and do that. At one point back in the early 2000s, we did a thing where we had a meet and greet for the primary care docs in our community and mental health professionals in the community, to talk to each other about referrals and get to know each other and find out things about each other, which was certainly not sufficient, obviously, to have a single one. But I think that outreach to talk to people and say, all right, I see this whole spectrum of kids. Do you see kids under age 10? Do you see kids over age 10? What are how could we work together on this? Can we have a way that we communicate? Right? I always make the joke that you tend to know the cardiologist or the ENT you're sending a kid to. And, the standard is you're going to get some report back, but we haven't done that with our mental health colleagues. And I don't understand that exactly, except that we have had this talk about perpetuating stigma. We can't talk to each other. We can't, engage in those kind of relationships, but I want to have a referral relationship with people. If I have families I care about that are part of my practice, I want to have as many referral relationships as possible, so that when I am suggesting a referral for a family, that I have some knowledge of who that is and what's going to happen. And I know I'm going to have some communication afterwards. I think it's much easier. I think people get more confident about, oh, you know what, I can manage this. I can start the conversation with the family about this. It's not totally foreign to me. I can start talking about it. It's an amazing effect when people have that, work together enough that they say, okay, I am not a psychiatrist, but I can talk to this family and I can do some of these early steps. I can make suggestions to them while we're waiting for a referral. I can do that because now I'm a little more comfortable with what I can do to support the family while we're waiting for a referral.
Absolutely. Yeah, that's I think speaks to the, another aspect of this integration, which is not just around the handoff, because the handoff is sort of, a part of integration, that we have to work as a team and we have to say, well, we're going to ask this other person to help you, and we know specialists need to be involved as well. But really, when we make that handoff, like, we often think about, the success or failure of the handoff is whether the person gets to see the other person. But I think the real success is not only whether the person gets to see the person, but whether you get information back, from that person, and whether that person is actually, sort of the work of that person is being coordinated into the overall management of the person's health. And that involves kind of an ongoing relationship, and part of the relationship is good communication, and allowing the primary care provider to still be connected, so it's not like you're throwing the mental health issue over the fence, and sort of asking someone else to deal with it, which you need. But you're sort of just handing it off to someone who's still on your team and you're still engaged, and whether that's a specialist outside the practice or whether that's a specialist in the practice, I think that's what integration really means. It's not just ensuring that the person gets the service. It's really sort of how the service is being provided and how it's connected. So I love that point. Marion, there was a question, a really good question that came in from the audience, which I just saw, and it's about, and actually it was perfect cue, because the next topic I wanted to bring up, for the last little section of this session, is really for us to talk a bit about the issue of race and ethnicity and how that relates to stigma. And so the question is a good prompt for that discussion. And the person who asked the question basically pointed out that the American Psychological Association recently came up with a statement really calling for ownership of the medical profession and the mental health profession for sort of this kind of discomfort, that people, experience, that we often sort of make the assumption that people of color don't want to get mental health services because they have all this internalized stigma about mental illness. And that may be true with some people, that they have some belief systems, that, mental illness is kind of a bad thing, and that it's sort of a shameful thing or something that's kind of disgraceful in some way. But the bigger factor, which has been well described, is that there is a mistrust, of mental health professionals and medical professionals because of the legacy of racism and white supremacy that has existed in our own practices. And so the APA, the psychological APA, came up with a statement, calling for apology to people of color for the APA's role in racial discrimination and human hierarchy in the US. But I wonder if we can speak a bit about some of the work that you and I did in that racial justice initiative with Hopkins around trauma-informed practice and sort of bringing a racial justice lens to trauma-informed practice in primary care. What are some of your thoughts about that?
Well, the first thing that occurs to me is that, all of us in healthcare, whether it's mental health care or not, have got to really intentionally think about the institutional racism that has limited access to people of color for a very long time. And if you look at the data around health disparities other than mental health, it's striking, it's startling, right? And we all have a part in that. In how do we make this a place where people want access, right? So I think that's true in health in general. And in addition to the project we just did with Hopkins, the project I'm working on with the American Academy of Pediatrics is very much oriented towards that. The Academy has made anti-racism a top priority. We've had the statement that came out about the impact of racism on child and adolescent health. And so I think we all have to own that in healthcare and do some pretty radical things to ensure racial justice. So in this project, which you teed up, we had practices that had already done work on trauma and resilience informed care, and then really tried to look at their institution and how they delivered care and their community and how they were responsible to their community, and in really furthering racial justice. And it was a really a dramatic experience for myself and for Barry too, in the sense that the sense of urgency that these folks really felt to make those kinds of changes, and then figuring out how do you do that? How do you change your organization and your hiring practices, and how do you make restitution to the communities that you serve in terms of how you've served them. It was, and I was really left when we were talking at our last session, I really have that, I was really struck by that sense of urgency to do this work. I don't know.
Yeah. I mean, so it's kind of a whole separate topic. I think that we are planning to devote a session of the clinical conversations to the whole topic of racial justice in pediatric primary care and how that relates to mental health. But I think in the context of the discussion about stigma, I think that, of course, we have to, sort of continue to educate people about, our understanding about mental illness and normalizing it, and trying to sort of have counter narratives, to, for people who do have these internalized beliefs, that, mental illness is this terrible stain and that it's not, sort of safe to talk about it and things like that. But I think that the other part of that is really just really acknowledging that it's not just internalized stigma that prevents and makes it difficult for people of color to have conversations with us, about mental health issues, that it's as much about the relationship that we as members of the mental health and the medical profession, have not sort of adequately cultivated with communities of color, and that there are real trust issues that have nothing to do with stigma, but that reinforce stigma, and that make it more and more difficult and really compound the difficulty of people of color in really engaging with us around mental health issues. And so a lot of that, it's very complicated. It's very challenging work. It involves really sort of being willing to put yourself into a discomfort, position of discomfort, where you're acknowledging sort of ways in which we have, as white people or people who identify as white, have really discriminated against people of color and have not adequately addressed, a lot of the needs of people from communities of color in our practices, and have not sort of made our practices adequately accessible, and have not really learned how to talk with people about issues around racial trauma and discrimination. So a lot of that stuff is sort of just going under the surface. It's having a major impact on the mental health of the people that we serve in our practices. And a lot of times we're just kind of oblivious to it and not addressing it, clinically. And so there's a lot of work to be done to try to reverse that condition, and we can't control it, completely, because it's a large systemic, structural issue, but it's a major sort of need, and it looks like we're running out of time, or we have run out of time. But Mary, do you have any final thoughts to share?
No, just that it was great to be able to have this conversation, and I hope that we do it again and again, right? This needs a lot.
Thank you so much for taking the time to join us today, Marion. And we didn't have too many questions from the audience. We had a small audience today, but it was nice to have people, engaged in listening to us. And again, this will be recorded, and we do want feedback. So if you get this pop-up, which you should get at the end, or an email, then we will read them carefully so that we can learn from your feedback. But thank you so much, and have a happy Thanksgiving, everybody. And we will see you again in January, because the December session is not going to take place because it's falling right in the middle of the holidays. So thank you so much.